Good morning. From this side is just after 10 a.m. Okay, those my lips are dry. So today I'll be taking off from where I stopped yesterday. I'll be finalizing on renal pharmacology. Yesterday we were able to do the carbonic anhydrase inhibitors, the loop diuretic, and the thiazide diuretic. Today I'll be doing the case pairing and also RAAS inhibitors and ARB. Okay. Yeah. So, um, just a little bit of background. My name is Kemi, and I'm on a journey to becoming a medical doctor. Let me make sure my sound is good. Just a moment there. So, on this journey, what I'm gonna do is just study every day. Every day. I have my NBME exam next week for renal. So we'll see how that goes. The network is not good. What's happening? Um, to recall a few things we talked about yesterday, the thiazide diuretic. Okay, so my volume is working today. My sound is working, which is good. That's a relief. Now I can study, but I'll do a quick recap of what I learned yesterday, starting with the thiazide diuretic. All the drugs end with IDE, so that's a easy way of knowing them. Sorry. Okay, so all the drugs end with hi everyone, thank you for joining me. So the format today is I'll study for 30 minutes and then we'll chat for 10 minutes, then continue another topic for 30 minutes, and then we'll chat for 10 minutes. Yesterday, we were able to do, hi, Sopian. Thank you for joining me today. Thank you so much. Um, so, yesterday, we were able to do pre-diuretics, the carbonic anhydrase, the loop diuretics, and thiazide diuretic. So I would do a recap, starting with the thiazide diuretic. All the medications there, they end with the suffix IDE. I'm sorry, did I say IDE? I mean, they have the word thiazide in them. We have hydrochronic thiazide, we have chlorothiazide and clota, clothiazide, but those are the medications. And what they do is that they inhibit the sodium chloride co-transporter channel, and this would lead to increased excretion of sodium and chloride from the body. Um, or yeah, it leads to increased excretion, and this is done at the DCT. That's where this happens, and therefore it will also lead to increased absorption of calcium, increased excretion of potassium and hydrogen. Okay, so this medication we use it with patients that have hypertension. It's also used for edema kind of situations like pulmonary edema or even heart failure. Yeah, liver cirrhosis. Those are the places we use it for, and it's also used for nephrotic diabetic insipidus, when the patient has recurrent kidney stone. This is also very useful. It has some side effects, which one of them would be metabolic alkalosis, as a side effect, and also it increased sulfur allergy. Sulfur allergy like sensitivity to sun, rashes on the body, and all those. Okay. Electrolyte effect that it does is that it has hypokalemia and hyponatremia. Those are the two hypo. So reduce nitrate and potassium in the body. And it also increases hyper glucose, that's glycemia, lipid, lipemia, uric, and calcium. So GLUC, glucose, lipid, urea, and calcium is increased in the body. Hello, thank you for giving me my first like. Happy to see that. So my name is Kemi, and I'm just studying for renal system. I'm a medical student. I have my um, board exam next week on renal. And so we are all in studying. I will just continue with the recap, after which I will now continue to study for 30 minutes, then talk for 10 minutes. The next one I would like to talk about is the osmotic diuretic. An example is mannitol. So osmosis is like water will move from a region of low concentration to a region of high concentration. So what mannitol does is to draw water. Okay, so it draws water. That means it can increase your urine output. Hi, Marik, how are you doing? Thank you for joining me today. um, yeah, so it will increase urine output. It will increase osmolarity pressure, reduce reabsorption of water. It's drawing water away. It's used in acute glaucoma and mountain. Okay, not this one. The one used in mountain sickness will be carbonic anhydrase. So this one is used for acute glaucoma and cerebral edema to draw water away. So that's what it does. Its effects, since it's drawing water away, one of the major effects will be that it can lead to dehydration. It can also cause hypernatremia, or even hyponatremia, depending on how it works. It can lead to pulmonary edema because too much fluid would be in the extracellular space. When not to use it, if the patient has congestive heart failure, we don't want to use it, or if the patient already has anuria, which is like the patient's urine output is very, very low. They already have difficulty urinating, so patient will have difficulty excreting mannitol because they don't have enough water in their body, so mannitol will just be stuck there. So we don't want to use it in those two situations. The patient already has heart failure or anemia. Hi everyone, thank you for joining me today. My name is Kemi, and I'm doing a recap on what I studied yesterday for renal. The next one I really like to do is so I forgot to tell you the mannitol, which is osmotic, works in the PCT. And the next one I want to do is carbonic anhydrase. It also works in the PCT. Mannitol, we use it for patients with acute glaucoma and cerebral edema. However, carbonic anhydrase, we would be using it for patients with mountain sickness and also acute glaucoma. One of the major drugs there is acetalamide. Yeah. So this one blocks the reabsorption of bicarb. Bicarb. So it blocks the reaction of bicarb, reabsorption of bicarb in the body. So it reduces the reabsorption. Therefore, bicarb is excreted more. It does not allow the reaction of carbonic acid, where it breaks down to carbon dioxide and hydrogen to take place. So that's what it does. It's a weak diuretic and it works in the PCT. I already said the use would be for glaucoma and mountain sickness. Mountain sickness because when you are in high altitude, the carbon dioxide pressure drops. This will lead the body into hyperventilating. Okay, and when the body is hyperventilating, your CO2 level will drop and lead to respiratory alkalosis. The body needs to compensate by going through metabolic um, acidosis. And to do this, acetylcholine helps to increase excretion of bicarb in the body. Hi, Bisim. How are you doing? Thank you for joining me today. My name is Kenny, and I'm studying for med school. Okay, so it's also used to reduce production of CSF in the brain and reduce the production of aqueous humor in the eyes. I remember now. Yeah, so that means it helps in those two things. Adverse effect will be hypokalemia, kidney stone, and also contradiction during usually a patient that has sulfur allergy or metabolic acidosis. The next and the last one I'll be revising before I start to study for 30 minutes will be loop diuretics, and this one works in the sodium potassium to chloride. Yeah, so it blocks the NKCC channel, and this means that the reduce the potassium movement back into the lumen. Therefore, it would in turn reduce the para transport of calcium and magnesium. So it will reduce the para transport of calcium and magnesium. It then would increase exchange of sodium and in the density. Okay, so therefore, sodium, potassium, hydrogen would be excreted more in the density. And these loop diuretics are emergency drug. We use it in case of emergency. For example, somebody is having pulmonary edema, fluids in the lung. We're going to use loop diuretic or hypertension, although it's not the first drug of choice for hypertension, but it's the first drug of choice for pulmonary edema and heart failure. Okay, the side effect is ototoxicity. It's possible for the person to lose hearing balance or hearing. Okay, when they use this drug, that's a side effect. It can lead to allergic reaction, um, and metabolic alkalosis. It also has acute interstitial nephritis, can be a side effect. For the electrolytes, it leads to hypokalemia, hypomagnesium, since it's not allowing calcium and magnesium to be reabsorbed into the system. So it leads to hypokalemia and hypomagnesium. Another one is hyperuremia in case of gout or hyperglycemia. Example of drugs in this situation is furosemide, yeah, and ethanic acid. Now, if the person has sulfur allergies, you will use ethanic acid, but if not, furosemide is the best or the drug of choice for this. Hi everyone, thank you for joining me. So that's a recap from yesterday. Today I would do potassium sparing diuretics. So it's time for Kemi to study for 30 minutes. You might not hear my voice for 30 minutes, but after that, I will come and we'll chat again. You can ask me any question in the comments. I will definitely respond to your questions. Thank you so much, guys, for joining me today. I people ask me like what I'm studying with, and I will say for now I'm studying with bootcamp. Okay, I'm studying with bootcamp for now. Um, and for now. When I'm done with this, I would go to do some questions in real world, and also I'll look at Amboss. Okay, let's get started. Okay. Mm. So, aldosterone antagonist is an inhibitor of aldosterone effect. It will reduce the reabsorption of sodium. And wherever sodium goes, water goes. So if sodium is not reabsorbed, it means that water is not reabsorbed. Hence, sodium is excreted, water is excreted. Therefore, you have an increase in urine output. That makes sense. Okay, increase in urine output could mean a decrease. Urine is alkaline, right? So that means hydrogen ion, which is acidic, will have a reduced excretion of that because now your urine is alkaline in nature, so it cannot be alkaline and acidic at the same time. Therefore, that means this particular one, aldosterone antagonist, leads to acidosis because hydrogen is not excreted, it remains in the system, then the system is acidic. Makes sense? The second one would be the NAC blockers. This one would inhibit the NAC channel. Here we have tramtaurine, amyloride. Um, so what did this one do? They block inner channel. Hello, please join me with the Q&A. Who do you think is an artist everybody should listen to at least once? Yoruba was said Nathaniel Bassi. Nathaniel Bassi is a gospel musician, though, yeah, Nigerian gospel musician. I think he played in the United States White House recently. Yeah, he did. I think for Trump inauguration or something like that. Yeah, interesting. Okay, so NAC blockers will inhibit the NAC channel. That's the sodium excretion channel. Is that it? Let me look for the full name. So it's pronounced INAC, okay? INAC channel, and it's the epithelial sodium channel. Can you imagine? Epithelial sodium channel. I said excretion. Epithelial sodium channel. So pronounced INAC. Okay. So if they inhibit epithelial sodium channel, that means sodium is not going to be reabsorbed because they block that channel. That means if sodium is not reabsorbed, it will definitely increase our urine output, but also means that calcium will be reabsorbed, hence a reduction in calcium's excretion. That's a calcium, I mean potassium, the K one, excretion, potassium. Therefore, increase in urine output. So the case pairing ones, what they do is that they reduce the excretion of potassium, unlike loop diuretics and thiazide diuretics. So this case pairing will definitely lead to hyperkalemia. That makes sense. They're not allowing um, potassium to leave the body, so the body is going to be in an hyperkalemic state. And because urine is being excreted, water follows urine. That means water is being excreted, hence increase in urine production. The drugs here for ENaC blockers is trimethoprim and aminoride, and for aldosterone antagonists, which also inhibit the effect of aldosterone, reduce sodium reabsorption, therefore increasing urine. Another, so they have two types of case pairing: aldosterone antagonists and ENaC channel blockers. So for aldosterone antagonists, the drugs are ciprolactam, ciprolactone, ciprolactone. Okay, makes sense. Impotence. Wasting. Okay. So adverse effect, we have hyperkalemia since they are potassium sparing. That makes sense, right? Uh, so that means we can use them with loop or thiazide diuretic because those ones lead to hypokalemia. So if the potassium level is too low in a patient that is on loop or thiazide diuretic, then we would switch to um, K-sparing to bring up the calcium because K-sparing is hyperkalemia. And it also has some other effects like they call it anti-androgenic effect. An example is androgenic, so that will be aldosterone antagonist like spironolactone. Okay, and the effect is what? Okay, another thing I just learned is that hypokalemia would present with U wave, whereas hyperkalemia would have IT wave or long P and R interval or sine wave tachycardia. So those are the EKG presentations. Great. Now I get to do some questions which I cannot tell you, but once I'm done with these questions, we will treat some questions I will create myself, the help of ChatGPT. Uh, I mean, I missed that. I did not write down. So, case pairing works on the collecting ducts. Okay, works on collecting ducts. So it works. Mm, which do you know some signs? Sorry, Baba. Do you know some signs of heart failure? We have swelling in the abdomen, swelling in the legs, fluids surrounding the lungs, chest pain, enlarged liver, tiredness and shortness of breath, raised JVP. What's JVP? Jugular venous pressure. Okay. Do you know some of the symptoms of heart failure? We have swelling in the legs, swelling in the abdomen, enlarged liver, raised jugular pressure, chest pain, tiredness, tiredness and shortness of breath, uh, and fluid surrounding the lungs. Okay, so when I say swelling, that's the layman term. We would say edema. So edema in the lungs, edema in the edema in the abdomen, edema in the legs, enlarged liver, raised jugular pressure, shortness of breath and tiredness, and fluids around the lungs. All these are symptoms of what? Tell me in the comment section. So this is Crohn's disease. Crohn's syndrome. Okay. Learning every day. So Crohn's syndrome is known as primary hyperaldosteronism. So in Crohn's syndrome, you experience elevated aldosterone. So in Crohn's syndrome, you experience elevated aldosterone and mm, okay. So in Crohn's syndrome, you experience elevated levels of aldosterone and low level of A. Renin, B. Aldosterone, C. What? I don't know. Hmm. In Crohn's disease, in Crohn's syndrome, you will experience an elevated level of aldosterone and a low level of which of the following? A. Renin, B. Insulin, D. What am I saying? C. Cortical. Let me know in the comment section. A 58-year-old patient with heart failure is prescribed a medication that completely inhibits my mineral corticoid receptors in the collecting duct. Which drug was likely added to their regimen? A. Amiloride. B. Mannitol. C. Cipro- Spironolactone. Or D. Acetazolamide. I'll take the question again. A 50 A 58-year-old patient with heart failure is prescribed a medication that completely inhibits mineralocorticoid receptors in the collecting duct. Which drug was likely added to their regimen? A. Amiloride. B. Mannitol. C. Spironolactone. D. Acetazolamide. And the correct answer is C. Spironolactone. Another question. A researcher is testing a diuretic that causes mild sodium loss without affecting gene transcription in the nucleus. Which of the following is the most likely target of this drug? A. Sodium potassium pump. B. Carbonic anhydrase. Or C. Epithelial sodium channels. And the right answer is C. Epithelial sodium channels. That's pronounced ENaC. Where is the anatomical site where both aldosterone antagonists and ENaC inhibitors exert their primary therapeutic effect? A. Collecting duct. B. Thick ascending lip. C. Distal tubule. Or D. Proximal convoluted tubule. And the right answer is A. Collecting duct. So that. So we'll do more questions shortly. Kindly subscribe to the channel. I'll be using this weekend to post all the questions we did this week. So you might want to do a revision with me. And here comes the next set of questions. Okay. Okay. A 62-year-old male with chronic heart failure and okay, let me start again. A 62-year-old male with chronic heart failure and reduced ejection fraction is started on spironolactone. Which of the following best describes the primary electrolyte change targeted by this therapy in the collecting duct? A. Decreased reabsorption of magnesium. B. Increased secretion of potassium. C. Increased reabsorption of chloride. Or D. Decreased reabsorption of sodium. And the right answer is D. Decreased reabsorption of sodium. Next question. A patient taking high dose spironolactone for hepatic cirrhosis undergoes blood gas analysis. Which acid-base disturbance is most likely to be observed as a direct result of this medication? Effect on the intercalated cells. A. Metabolic acidosis. B. Metabolic alkalosis. C. Respiratory acidosis. Or D. Respiratory alkalosis. Thinking. And the right answer is A. Metabolic acidosis. So there we have it. Yeah, just checking to make sure my sound is working. Okay, let's go to the next question. Now, large clinical trials have demonstrated that adding cypronol again, large clinical trials have demonstrated that adding spironolactone to standard therapy for severe heart failure provides which of the following long-term benefits? A. Increased mortality rate. B. Rapid reversal of pulmonary edema. C. Increased overall survival. Or D. Improved glycemic control. And the correct answer is C. It increases the overall survival because it is a mortality reducing drug in heart failure. It prevents aldosterone mediated cardiac remodeling and fibrosis. We'll do one more set and we'll call it a day on this topic of case bearing diuretics. And remember, we have two. We have the inner channel blockers, and we have the aldosterone antagonist. Aldosterone antagonist, an example is the spiral. I'm always biting my tongue when I try to pronounce that one. The spironolactone, and for the inner channel blocker, we have the amiloride and the trimethrin, something like that. Yeah? Okay, so the next set of questions are here. So, show my hands. I'm a full human being. Okay, so a 45-year-old patient with chronic liver disease presents with significant abdominal swelling. Which of the following diuretic is specifically indicated to manage this patient's ascites while improving long-term outcomes? A. Furosemide. B. Mannitol. C. Acetazolamide. D. Spironolactone. I'll take the question again. A 45-year-old patient with chronic liver disease presents with significant abdominal swelling. Which of the following diuretic is specifically indicated to manage this patient's ascites while improving long-term outcomes? A. Furosemide. B. Acetazolamide. C. Mannitol. And D. Spironolactone. And the correct answer is D. Spironolactone. Treated for bipolar disorder with lithium develops polyuria and polydyspear. Okay, which medication can be used to block the uptake of lithium through the ENaC? ENaC, we have amiloride and trimethoprim as a two drug of choice. So that should be the answer. Correct. Good. Now we can do it. So what I do is like I test myself on the questions generated by Gemini first, and then I would read it to you and tell you the answer. So when I miss it, I'll just tell you the correct answer. And when I get it, I'll bluff and say, oh, I got it. Funny. Okay, let's do it. A patient being treated for bipolar disorder with lithium develops polyuria and polydyspear. Laboratory test confirms nephrogenic diabetic insipidus. Which medication can be used to block the uptake of lithium through the ENaC? A. Amiloride. B. Spironolactone. C. Ramipril. Or D. Hydrochlorothiazide. And the correct answer is A. Amiloride. Ooh, I like this one. Oh, I was that close. I got it wrong, but I was that close. I was torn between two options. Uh, but this is helping me too, you know. So let's do the question. A mountain climber taking acetazolamide to prevent altitude sickness is at risk of developing which of the following electrolyte or acid-base disturbance? A. Metabolic alkalosis. B. Hypernatremia. C. Hyperkalemia. D. Proximal renal tubular acidosis, known as RTA type 2. And the correct answer is D. Proximal renal tubular acidosis. And there we have it for this. I'm done with the questions and studying of the what's it called? case-bearing diuretics. Now I'll move to the very next one. I have to study. Hopefully by tomorrow, I should be able to do a lot of revision. So we're gonna end this live stream now. I need to take a break. Then I'll come back and we will do. What are we doing next? Let me see. What are we doing next? What are we doing next? Next we'll be doing um ACE inhibitors, renin inhibitors, and we'll work on all those when I come back. Thank you for joining me. I'll be back by 12 p.m. So 30 minutes break, and I'll be back. Bye.